Thank you very much. Good day to you all, and thank you, ESOG, for allowing me to be one of the panelists. I'm given an area that is very important, but least vested on, because during the pandemic, focusing on education is not in the top lists, because the service is the one that is prioritized. And the Ob-Gyn residency program, like other clinical or surgical residency programs, is going to be affected with COVID, because residency by its nature needs a competency that has to be acquired during a given time. And it has, as you all know, it has 3 pillars. Okay, the teaching, learning, acquiring basic knowledge, advanced knowledge relevant to the discipline. Okay, service provision as it at the level applies, and undertaking and understanding research. So this is the novel curriculum that we used to give residency Ob-Gyn training in the country for the last maybe 25, 30 years. And as a country, unlike other like Central African countries, our experience with pandemic, let alone COVID, but other, recurring pandemics is very low. So Ethiopia has never seen anything like this or closer to this that could affect the teaching, learning, and especially the residency program, okay? So our curriculum is in no way prepared to face the challenge that our residents will have. Another thing to note is that residents in other like developing countries, they are not frontline health providers. They are contingencies to the frontline providers. But when you bring it to our reality, residents are actually the frontline health professionals in most teaching institutions. Okay, and of note again is since recent years, maybe for 5 years, our residents are coming with very limited exposure to the obstetric and gynecology practice during their general practitioner era. Because that field is being covered by other health professionals. So the residents that are coming to us, and currently they have least exposure to the obstetric practice. They are in the era of a pandemic where our curriculum has no flexibility per se, and they are expected to give service, not to get the learning first, because in the pandemic, the axis shifts. There will be, the axis shifts in a way that the resident should be a primary care provider first, then the system should maintain the health of the resident to drive the service, and continuing the education without compromising quality will be the third order. So it is not easy. It is not easy to run a residency program in our situation, because we are held off guard by COVID because of our existing infrastructure. Most of our services still manual. Our patient service is by the bedside, okay? And our skills are acquired in the operation theater, where we have a group of residents and the skill transfers will be on hands. So it is very easy to understand that residency programs will be handled very differently in a country like ours. Another thing related with COVID is, as Dr. Yigeremu has put it, patients fear us, we fear our patients. We don't know which one is giving and which one is taking, okay? So that creates an anxiety. There are international literature evidences that the anxiety level of residents and poor stress management of residents could reach up to 50%. And we have no way of handling that. Okay, we have no answer. So during this difficult time, I think I have been leading a good program, because the College of Health Science was trying to help programs run alongside the clinical services. As Dr. Yigeremu has said, the formation of the emergency operation, I think it's called center, yes. It has been guiding not only the service and the health provider, but also the teaching learning programs. We didn't have protocols on how to handle the situation. So the EOC provided weekly brochures and daily updates, especially the first 8-10 weeks. We had daily updates on how to handle incidents during the service as well as during the trainings. Our residents were the lead anxious. Remember, we have residents who say that they have symptoms and we didn't have a test to confirm or not and to place them in the workplace. The guidelines on how to treat the suspect was not clear at the beginning. The month of April was the craziest, I cannot tell you. So that the leadership by the EOC and the later accusation of the testing capacity at Black Lion helped somehow normalize the situation. The situation, that means it introduced some degree of calmness in the Residency program. So what was done after that is at the department level, in parallel with the EOC, we have a departmental committee that runs the residency program. As you all know, we have 3 affiliate hospitals, the Gandhi Memorial and Zawditu Memorial and the Black Lion Hospital. So what we tried to do in line with that, the EOC, is that we tried to manage our workforce. So the initial thing was to reduce the number of residents exposure to the clinical practice, so that we created a kind of like weekly rotation, so that residents will be off the work while keeping them safe. So during that time, because our infrastructure was paper-based, still it is, I mean, we are trying to be digital, but it was. So what happened was the quality of the service could not be maintained. Because the residents change every week, we could not continue the continuum of care that the training required, okay? So we have to really revise our decisions by the end of April. That program did not continue after the month of April. So we have to revert back to our older sessions. Rounds of trainings were given by the EOC, especially on the safety of our residents, which is a priority, and access to PPE was available even starting from the month of April. And staff members even generated resources. They raised funds among their diaspora friends, local friends, and they purchased PPE material to the hospital and the department, which was a very good act that our residents would be safe. The other thing is that clinical rotations, which are very important per the curriculum, were held for a while because our residents need to go to the other departments, but other departments could not accept our residents because of the international recommendation that residents are better have a fixed place for training. So we could not do that because we could not have anesthesiology training in the Department of Obstetrics. We could not have ICU training in the Department of Obstetrics. So we had to negotiate between different departments on how to drive the curriculum while keeping our residents safe. So what we did is we reduced our number of residents in the same hospital, but we increased the hospitals for such services, and that has been going on since then. Fortunately, by the due nature of the obstetric training, the caseload in obstetrics actually, which was 50% less in the month of April and early May, it increased, okay? And our obstetrics training is not that much affected. The caseload exposure is very good, even more than it was in the earlier years. But when it comes to gynecologic training, it is seriously affected. Number one, there is an international recommendation that electives should be postponed as much as possible. And number two, now we had to test gynecology cases, and if they are positive, definitely. And the patients were not coming. So we have a very serious gynecology caseload reduction, and our residents were least exposed on that area. So what we did was we introduced a minimum requirement for residents to have a competency in gynecologic surgeries, and especially for our final year residents which graduated this year. What we did is we gave them a number of procedures that they have to do, and we prioritized them because they did not have the time. And we are fortunate that we had the needed number of cases in the 3 hospitals, especially the Zewditu Memorial Hospital. I have to thank them, the administration. They have created a platform for our residents to have gynecology care exposure, and they had achieved their competencies and they have graduated. So with still the posed threats by COVID, we have a fear in ASA program that the gynecology component of the training will be affected unless we have other means of acquiring those skills, which we don't have the infrastructure. Telemedicine, as has been raised, is a very valuable means of acquiring skill. SIM training is very important. We have one simulation center, but it is not well equipped. And the hands of training should be augmented by video surgeries and so on and so on. So the technology has to come really fast to make our programs strong. But another good thing is that the development of the natural protocol in caring for the COVID patients with pregnancy, it has really helped in the management of cases, okay? And it helped us pass that bad time. It was not easy to operate on COVID positive patients in a hospital that is designated initially non-COVID. Another very good thing that the college has developed is there is a home-based application developed for managing stress of residents, anxiety of residents. It's called the Selfcare application that's developed by the psychiatry department of the College of Health Science. It is a free application that is downloaded to any Android phone, and it helped a lot. I mean, it helped a lot, and now people have even a professional to talk to if they have such problems. So all the didactic programs initially were taken to the online. The university has purchased a Zoom function. So all our morning sessions, seminars, graduate management sessions, case discussions, everything was initially online. But the limitation that we have, if you remember, is that the power interruption was so frequent. Even if you have such a function, we could not use it fully. The other thing is the affiliate hospitals, even if they have the service, our residents did not have access to such a service. So residents had to have a personal cost incurred to have online trainings, which cannot be sustained for a long time. So with all those things, now we are reverting back to face-to-face. So infrastructure, internet access, with all the digital platforms we envision to live with COVID, it is like a mandatory situation that we have to have. In addition, I think as a resident, as a chair to the postgraduate program, I think nationally, we need to have our own new norm, new norm for training our residents, competent residents, future OB-GYNs, because neither the international recommendations nor our current existing situation make it easier for the graduate program to run and achieve its objectives. So I call on ESOG and other partners that the residency program is a very critical program to continue delivering maternal and child health services. We are going to live with COVID. I don't think scenario 2 is going to happen. So I think everybody, partners, Ministry of Health, ESOG, and other associations, they should also be on board on bringing the residency training quality, because I don't think we are the only ones affected. I think other programs are also, I know ophthalmology post extended their training time because the competencies cannot be achieved. So this is what we did. Thank you very much.
Thank you very much.